So please join me in welcoming Dr. Matthew Matassar. He's got a fan club already and he didn't even get up. Dr. Matassar is an attending physician on the lymphoma and adult bone marrow transplant service, as well as on the adult long-term follow-up service at Memorial Sloan Kettering Cancer Center. He's also the director of the Lymphoma Survivorship Program. Joining Dr. Matassar today for the Q&A portion of the session is Ms. Tracy Krimmel. Ms. Krimmel is the supervising advanced... Oh, we got a good group. And so early in the morning, too. Ms. Krimmel is the supervising advanced practice nurse with the Hematology Bone Marrow Transplant Program at the Rutgers Cancer Institute of New Jersey, Robert Wood Johnson Hospital, where she's worked with transplant patients and families for the past 17 years. So you should all have a copy of the PowerPoint, which Dr. Matassar will be presenting, and I'm not going to turn it over to Dr. Matassar.
Good morning, everybody. Thank you for coming out to this session, and I want to thank this is really just an amazing setup that they've done, the amount of effort that's gone into this morning and these 2 days is really tremendous, and it's absolutely my pleasure to be here and get a chance to speak with you guys. I'm very grateful to have a few friendly faces in the audience, and for those of you that don't know me, I'm not a very formal guy. I'd much rather sit around the table and get coffee and talk about these things than go through a formal slideshow. Okay, I'll use the mic. But what I try to do today for you guys is to put together just an overview of some of the issues that survivors of bone marrow transplant face. You can't cover everything about medical survivorship issues in a half an hour. I wouldn't even try to do so. But to give us an overview of some of the issues that various people may be facing, how we think about these issues medically, and what types of things we can do as a partnership between doctors, patients, and caregivers to safeguard the survivor's health in the long run is really what I'm going to try to achieve with you guys during this short session. So as a brief roadmap for what we're going to try to accomplish during this little time together, I'm going to touch on what it means to be a BMT survivor from a medical standpoint. What are some of the long-term health issues that you guys as survivors face? And then how can we work together to prevent and manage these risks in order to safeguard your health? So first of all, it's a big room, right? There's a lot of us in here, but this is just a very, very little tip of the iceberg. There's a lot of BMT survivors statewide, nationwide, worldwide, and these numbers are only going up, thank God. And you see here from 1980 to the most recent numbers, which is 2012, the number of survivors of either allotransplant, both unrelated and related donor transplant, as well as autotransplant, are high and climbing. This is because, one, we're transplanting more patients because we're getting better at it, and two, we're getting better at taking care of people during and especially after their transplants to keep people healthy longer. Here's a little bit to show that even during that critical first year, we're doing better as time goes by. And even over the last decade, 2 decades, we're seeing improvements in our ability to get people safely through transplants. This is our allotransplants. The numbers for autotransplant are much, much, much higher. 1-year mortality rates after an autotransplant are 2% or less at most centers now, 5% or less worldwide. But even with the more risky allotransplants, we're good and getting better. When you get through your transplant, that brings us to being a survivor. And various people will define survivorship variably, right? Are you a survivor the day after you get your cells? Are you a survivor after you go through those day 100 restaging scans? I've always preferred the notion that as soon as you've gotten your cells, you're a survivor. It's the most inclusive definition, and it captures the fact that there's a lot of different aspects of survivorship, both from getting through the transplant recovery course to people that are 5, 10, 50 years out from their transplants. Survivorship is really this yin and yang, right? Where you have disease control. You've gotten this transplant for a reason. It's to treat an underlying illness, and usually a serious illness, an illness serious enough to lead to accepting the risks of a transplant, either autologous or auto, meaning from yourself, or allogeneic, or allo, meaning from a donor of some sort. So you need the disease control, but the treatments themselves carry their own toxicities. And these risks are what we sort of generally lump as transplant-related morbidity, morbidity meaning sickness, or mortality, meaning fatal sickness. So when you think about what goes into the risks of transplantation, it's really an amalgam, right? You have whatever the disease was initially that led you into that room getting those cells. You have your own underlying hereditary background, hereditary illnesses that may have contributed to your cancer or may contribute to other risks. You have aspects of your disease itself, these tumor-related factors, what type of histology the tumor was, what your disease biology is, where it was in your body. You have the treatments that you've gotten for the cancer, both initially as well as transplant, but the treatments such as radiation, chemotherapy, or surgical procedures you needed can all contribute to risks of late effects. You have the transplant itself, events that happen during the chemotherapy or during transplant itself. You have immediate post-transplant complications and medical late effects from transplantation that we'll be talking a lot about today. You have things that you can control, right? Your health behaviors. Are you a smoker? Are you a drinker? What type of exercise do you follow? What type of diet do you adhere to? And then just normal aging processes and other illnesses you have completely unrelated to all of this. All of these together interact in a very complex way as a network that end up defining what your risks are of having late effects from your transplant. Now, transplantation is a treatment for disease. It's obviously not a recipe for immortality, and everybody faces the end at some point. For survivors, when they die, may it be 5 years or 70 years from their transplant, what is the ultimate cause of death can give us some insights into what are the risks that our transplant survivors face. If you look at auto-transplant, the transplant itself is not as dangerous as an allotransplant in many regards, but the diseases that they receive that transplant for sometimes are not cured with the transplant. Particularly multiple myeloma, for which most auto-transplants in America are performed on an annual basis. An auto-transplant is a very powerful treatment of that disease, but is not traditionally considered a cure for that disease. And oftentimes those patients will continue to face challenges from their underlying cancer. Graft versus host disease, 1% for autotransplant, often will confuse audiences. And there is a very rare phenomenon where an autotransplant can cause GVH. This is rare and somewhat confusing even to people on this side of the microphone. But oftentimes these curves end up being a little bit of a fake out because patients will have an autotransplant and then sometimes need an allotransplant later in life and then succumb to GVH at that point. So it gets a little bit mixed up in the data sets. Organ toxicity from the transplant, this is typically heart, lungs, or kidney. Infection during or after a transplant. And then other is just survivors of a transplant that go on to die of old age or whatever other illnesses they have unrelated to the transplant. This is very different than looking at allogeneic transplants, either donor-related or unrelated. Relapse continues to be an issue. Cancer is a problem regardless. But then you start having real numbers of GVHD, and it's worth noting and highlighting that, am I still not being loud enough? Am I still not being loud enough? Can you hear me now? I'll swallow the microphone if I have to. It's worth highlighting that GVHD is really, in this modern era, quite similar between donor and unrelated donors. We're getting better at the transplantation techniques and modifications of graft versus host risk to the point that donor transplants, even if it's from an unrelated source, are not measurably riskier in this modern era than a related donor. And that's an amazing thing to be able to say. Infection risks continue to predominate. Then there's these unusual complications such as damage to the lungs from the transplant or other organs. So we're going to kind of go step by step and highlight some of the risks sort of on an organ by organ or problem by problem basis, just to highlight some of the challenges, right? So cardiovascular disease, if you look at non-cancer related cause of death, either not because of the underlying cancer or not because of acute graft versus host, cardiovascular disease continues to be the #1 cause of death. And that's either because of or despite the transplant, because heart disease is common in everybody. But we know that there's aspects of the treatments for cancer, including transplantation, that can heighten those risks that need to be managed by you and your caregivers. We know that getting types of chemotherapy called anthracyclines, such as medicine doxorubicin, the red menace, right? Or radiation therapy to the chest, or suffering from chronic graft versus host can all increase the risk of certain types of heart disease. Now, these can variably affect different things. Anthracyclines are notorious for weakening the heart muscle. Radiation therapy can either weaken the heart muscle or cause early hardening of the arteries or damage to the heart valves. Graft versus host disease tends not to weaken the heart muscle but can increase hardening of the arteries in a rapid way. The symptoms of heart disease, hopefully everybody in the room is at least somewhat aware of what it means to have, for the symptoms of a heart attack: chest pain, shortness of breath, pain under the jaw or the arm, palpitations. Strokes can be a risk for patients who've gotten transplant as well, particularly when radiation therapy has been given to the neck. That can cause hardening of the arteries of the neck, and a stroke is usually manifested by sudden weakness of part of your body or sudden confusion or slurring of speech. These are all medical emergencies and not to be taken lightly. These are 911 type problems. The treatment of these is usually co-managed by a cardiologist. But it's important to note that sometimes, particularly with heart disease, we can find these problems early, before they're causing symptoms, before you're getting chest pain, before you have a heart attack, before you have a stroke. And we have the ability to potentially prevent these with using medications in a preventative way. Medicines to lower the blood pressure, medicines to take stress off of the heart, medicines to prevent a stroke, such as aspirin. We're still learning as a profession who, how, and when to screen patients, to look for patients without symptoms, to find problems before they're problems. But this is of critical importance and an issue very near and dear to me. This is really my area of research within cancer survivorship, is trying to figure out the best way to look for problems before they're problems so we can prevent damage to the heart or the brain. But even without that great knowledge, we know that we have certain tools available to us: ultrasounds of the heart, dye studies of the heart, MRIs of the heart, ultrasound studies of the neck. We have these tools in 2014 to be able to look for problems before they're problems, and I encourage people who are concerned about their risk to speak about these options with their providers. As of now, the recommendations are just continue with regular assessments, consider your cardiovascular risks, and to try to live a heart-healthy lifestyle. What's that mean? It's regular cardiovascular exercise. It's a heart-healthy diet. Currently, we recommend the Mediterranean diet, which is a diet rich in vegetables, olive oil as your source of oils, consideration of trying to incorporate nuts into your diet, trying to avoid processed foods, trying to avoid excess amounts of fat, and moderation in alcohol intake. Speaking of diet, a problem that many of our allotransplant survivors face is something called the Metabolic Syndrome. While this isn't heightened in our autotransplant survivors, survivors of allotransplant, particularly those who received what is called total body irradiation, which I abbreviate often as TBI in the slides because you get tired of typing the whole thing. Patients who need total body irradiation as part of their transplant conditioning are at very high risk of developing what's called the Metabolic Syndrome later in life. And whenever we're calling something a syndrome, you already know something about it, that we don't really understand it that well. A syndrome just means a constellation or like a list of things that kind of go together, right? So it's high blood pressure, it's overweight, it's type 2 diabetes, it's having very high levels of triglycerides even while fasting. This package is called the Metabolic Syndrome, and it's very high in survivors of transplant receiving TBI. It's very hard to treat. You know, a doctor telling somebody to lose weight, it's a little bit of, well, thanks for the good advice, but how are we going to accomplish that together, right? Nonetheless, weight loss with whatever dietary approaches that you take, and there's a lot of good literature saying that there's a lot of dietary options out there and they're all equally effective. It's finding the one that works for you, that you can incorporate and be consistent with in your life, is really the very best treatment. And even a small amount of weight loss, 5-10 pounds, can lead to dramatic improvements in the cardiovascular effects of the metabolic syndrome. So you don't need to be a skinny mini, you just need to try to get yourself a little bit healthier to restore better balance. Secondary cancers, or second cancers, second primary malignancies, as we call them in the literature, are challenging for survivors. And it's challenging for us as doctors to talk about because we don't love harping on the fact that our treatments themselves can cause cancer later in life. It's a little bit depressing even for your doctors and nurses. One thing that's very important to remind everybody in the audience is that you still need to be going for regular age-appropriate screening. I can't tell you the number of times my patients have said, oh, I don't want to get the mammogram, the colonoscopy, the pap smear, the prostate test, whatever it is, because you're already doing all these scans, Matt, so why do I need to go and get all that stuff too? This is not at all the case. Our scans are very good for looking for what they look for. They're very bad for screening for small cancers. Sure, a CAT scan will find a breast cancer after it's spread to the liver or the bones, but that's not really what we're trying to accomplish. We want to find problems before they're problems. That's what cancer screening is about. So in addition to your regular age-appropriate standard screening stuff, there's some things that transplant survivors should be attentive to in addition. One is skin, and we know that transplant survivors, particularly allotransplant, particularly TBI patients, but really all transplant survivors, are at increased risk for skin cancers. This tends not to be melanoma. It tends to be the non-melanoma skin cancers, squamous cell and basal cell cancers. These are generally not life-threatening, but they can be disfiguring, and they're still best treated when they're small. Oral cancer, cancer of the tongue or the mouth, can be a problem, particularly for allotransplant survivors who have chronic oral GVH, chronic dry mouth, and an annual examination by a dentist is standard. And thyroid cancer can be a problem as well, particularly for patients who received radiation to the neck or patients who have underlying thyroid disease. And simply an annual thyroid exam, meaning your doctor feeling your neck and checking a TSH as well, checking a blood test for the thyroid is standard. There are some uncommon scenarios, but that are selective scenarios for which patients should have additional screening, or at least consider additional screening. The first is for patients who might be at increased risk for breast cancer because of the treatments of their cancer. This is typically for younger women, women under the age of 40, and particularly under the ages of 30 or 35, who needed to have radiation therapy to the chest as part of their treatment. Generally speaking, when you have radiation to the chest, it can also affect the breast tissue, and young breast tissue can be radiation sensitive, and this can increase the risk of breast cancer later in life. A woman under the age of 25 who needed to have radiation therapy to the chest for, say, Hodgkin lymphoma has the same risk of breast cancer later in life as somebody who has the hereditary breast cancer gene. These are not trivial risks, and we need to manage these risks appropriately. Currently, what we and other centers are adopting is a high-risk breast cancer screening program for such patients with an annual MRI and mammogram for at-risk patients. Radiation therapy to the belly is a little bit less common in this modern era, but for patients that still need high-dose radiation therapy, this is not TBI, this is real involved field radiation therapy to the abdomen, the pelvis, or even to the spine, can have heightened risks of colorectal cancer later in life and are likely to benefit from a heightened screening program starting earlier with colonoscopies than they otherwise might. And lastly, if there's radiation therapy that is given to the lung tissue, and again here not TBI but higher doses of radiation, patients might have a heightened risk for lung cancer. This is markedly higher in patients who have a smoking history. The combination of radiation therapy and smoking is about equivalent to living in an asbestos mine for about 10 years. And these patients are very high risk. Radiation therapy without smoking is a smaller risk, and it's hard to know whether such patients really do need CAT scans or not. And we have that as a case-by-case discussion between doctor and patient. Cataracts, not quite as serious an illness as second cancers, but still can be quite taxing on patients, and it's very common, particularly after TBI. But even high doses of steroids, as are commonly used during transplantation, can increase the risks. For patients with TBI, more than half of them will have cataracts by 10 years out. For other patients, it's still about 1 in 10, as high as 1 in 5. The symptoms are impaired night vision, impaired vision in general, trouble with driving and seeing the signs. Cataract procedures are very safe and very easy in this modern era. And simply you should all be going for an eye exam once a year regardless. And cataracts, if they're identified, can be intervened on successfully. Cataracts aren't the only eye problem that transplant survivors can suffer from. Glaucoma is a slightly more concerning condition. And for those that don't know what glaucoma is, it's the thing that this test looks for, where they do that damn puff of air in your eye and you flinch away 20 times until they finally get it. What glaucoma is, medically speaking, is elevated pressure inside of the eye. And that pressure inside of the eye can lead to damage to the nerve of the eye. And that can lead to impaired vision or even blindness in the eye. Screening for glaucoma with that damn puff of air, is very important for transplant survivors. We know that the risks are higher in transplant survivors, and that's probably related to the effects of steroids on the flow of the aqueous humor inside of the eye itself. There's certainly other risk factors. Having low thyroid function or having diabetes can increase the risk as well as high blood pressure. The problem with glaucoma, unlike cataracts, is that cataracts are all symptoms and not all that much danger. Glaucoma is the opposite. It's no symptoms and potential risk to vision. Our treatments for glaucoma are very effective when found earlier. It's simply eye drops for life, and 9 times out of 10 that can control the disease and prevent it from jeopardizing your vision. Rarely something like surgery is needed, but even that, if glaucoma is found early, can be highly successful. So see your eye doctors. The last eye problem that we can touch on briefly is this chronic dry eyes. This is a problem that autotransplant survivors rarely, if ever, face, but can be common in allotransplant survivors, particularly those who have chronic graft versus host of other organs. TBI type treatments as well as ongoing immunosuppression can increase the risks as well. What are the symptoms of chronic dry eyes? The symptom is chronically dry eyes, right? The treatment for it can be variable, and they're usually successful, although this can be a chronic and very nagging problem. And I'm happy that we have representation from ocular health groups here today, because it's not something that we take lightly. It's typically used with topical drops, either steroids or other immunosuppressives. And indeed, for those in the room that have ever had to receive cyclosporin as a treatment for graft versus host or prevention during your transplants, that's become a treatment for non-transplant patients with chronically dry eyes. We now have cyclosporin eye drops that regular people get too. So others are learning from our successes. The eyes aren't the only part of our body that can get awful dry for a long time. Chronic dry mouth, which can be associated with chronic oral graft versus host disease, as well as patients who need to get radiation therapy to the mouth or to the neck, particularly to the salivary glands, can again be a long-lasting and very taxing problem. Patients can have chronic dry mouth, loss of taste or abnormal taste, trouble swallowing, or even impacting their ability to speak clearly. I'm just a mumbler. It's not that I have chronic dry mouth. The treatments are somewhat supportive in nature. It's just trying to keep the mouth moist, gum, hard candies that are sugar-free so you don't get all the cavities associated with this problem. There are medicines called sialogens they're medicines that increase the production of saliva. Those can have side effects themselves, but for people who really suffer from chronic dry mouth, we will often give trials of those to see if the side effects aren't as bad as the effects. One of the sequelae of chronic dry mouth, of course, is increased risk of cavities, and people can have terrible, terrible burdens of cavities. So frequent and regular trips to the dentist. The guideline is annually, but oftentimes it's twice or 3 or 4 times annually. We'll keep sort of going down the body, so down from the mouth. We go to the lungs next. Lung damage to survivors is something that we really do worry a lot about, and this is both for auto and allotransplant survivors. In the post-transplant period, typically in the first 3 months, although it can be late as 6 months, for either auto or allo survivors, there can be this illness called idiopathic pneumonia syndrome, or idiopathic pneumonitis, which is a damage to the lungs that we think is caused indirectly by the chemotherapy and or radiation that was used. There are certain chemo drugs that we use in the transplant programs that are notorious for causing a risk of this, although the risk is always low. But when it happens, it could be a quite dangerous clinical situation managed with steroids and help from lung doctors, and is potentially life-threatening, although less so now than even 5 or 10 years past, as we've gotten better at managing it and identifying it early. There's this related disease called cryptogenic organizing pneumonia, or COP, and like most COPs, you don't want it in your life. This is more of an allotransplant survivor problem than an autotransplant survivor problem. It can happen as early as 1 or as late as 12, but it's typically a 6 to 9 month problem post. If you're a year out and you haven't had this issue, it's generally not going to be a problem. It also is dangerous but highly treatable. The last one on the list is in many ways the most concerning of the 3, a disease called bronchiolitis obliterans. It goes by other names, OB instead of BO, obliterating bronchiolitis, or constrictive bronchiolitis, CB, a lot of different names for the same illness. This is sort of chronic graft versus host disease of the lungs. And what happens is there's scarring and inflammation in the small airways in the lungs that can lead to shortness of breath or lung failure. It's a disease that we don't yet have a firm handle on managing successfully, and even now carries a high risk of severe illness. Our best treatment for it right now is to try to identify it early and to intervene early with steroids or other immune-suppressing medications. So I always encourage transplant survivors to talk about changes in their breathing or the onset of shortness of breath with their care providers earlier rather than later. Don't let this go and assume you're just out of shape or whatnot, because your doctors can identify problems early, and if they do, there's a better chance of fixing them. Yep, I had a whole other slide about it, I forgot. This is what I just told you. Iron overload is a little bit of an odd bird in the slide deck. The normal person gets about 1 milligram a day of iron in your diet. And the normal person loses about 1 milligram a day through sloughing of skin or normal turnover of the GI tract. So most of us are sort of iron neutral on a day-to-day basis. We absorb very little, we lose very little. We can't make ourselves lose more iron than we already do. There's no diuretic for iron. There's no easy way to make the body lose it all by ourselves. So if we end up taking in a lot of iron, we don't have an easy way to drain it out of our bodies. And if one gets a lot of transfusions, each transfusion can carry between 200 to 250 milligrams of iron, so about a half a year's worth of iron in a single bag of blood. That's okay. Our bodies can handle a lot of that. But there are some people that after as few as 20 transfusions, but typically more like 30, 40, or 50 transfusions over your life, start getting the risk for getting overloaded with iron, and your body needs to be able to put that somewhere. Normally our bone marrow serves as a reasonable storage space for extra iron, but if it gets overwhelmed, then the iron needs to go elsewhere, and it can be deposited into other tissues, particularly the heart and the liver, as well as sometimes endocrine or glands or joints, even the pancreas. So the symptoms are wherever you have iron depositing can cause problems. So arthritis, typically of smaller joints, diabetes if the pancreas is failing from too much iron. But the ones we really worry about are liver inflammation and heart failure. So sometimes there can be chronic liver damage or even cirrhosis from the liver being overwhelmed by iron. And sometimes there can be so much iron in the heart muscle weakens because of that. This is important to remember because when people have problems with their liver or their heart after transplant, to consider that iron could be a part of the problem. We have pretty good tests for that these days, including non-invasive tests like MRIs. Iron has a very characteristic appearance on an MRI. It shows up as pitch black because it doesn't have it has different magnetic properties than most of the body. And MRI capitalizes on magnetism. So we're good at finding it. And we do have good treatments for iron overload nowadays, either with simply phlebotomy, right, draining out your blood. That's a good way to get rid of iron. Or medicines that you can take intravenously or even orally that can help leach iron from the body over time. We have screening tests. There's a blood test called ferritin that doctors will often use both before and after a transplant. That is a reasonable proxy and a very cheap test to look for iron overload. And when a ferritin level is normal, the odds of there being damage from iron overload is very, very small. Chronic kidney disease is a challenge. And this is, if you think back to that slide where I showed you with all the different boxes going to the middle, chronic kidney disease is a very good example of that. There's hereditary factors, there's underlying diseases if you have diabetes or high blood pressure. There's the underlying cancer. Multiple myeloma itself can be hard on the kidneys. Chemotherapies that you might have received for your underlying disease, medicines such as cisplatin, a platinum-based chemotherapy, can be hard on the kidneys. And transplant conditioning and many of the medicines that patients get after a transplant, particularly an allotransplant, to help control the risks of graft versus host disease. All of these can put a stress on the kidney in one way or another. Chronic kidney disease doesn't have any symptoms, but it's very readily identified by your doctor, and your oncologists and primary care physicians are very often checking this, probably without your even being acutely aware of it. It's hard to see a doctor without getting a kidney test these days. There are things that we can do when there's signs of early kidney damage, medicines that can take pressure off of the kidneys in one way or another to try to reduce the stress on the kidneys and can help delay the progression of damage to the kidneys or even potentially reverse it. Many of the treatments, both auto and allo transplant, can put a stress on the bones and can lead to weakening of the bones, going from the situation where you have nice, dense bone with these normal little trabeculae or air pockets in it to a situation where the bone is more honeycombed. There's less solid and more air in there. When you have a little bit of this, that's called osteopenia, or mild weakening of the bone. When it gets severe enough that it's significantly weakened, we call that osteoporosis. So either mild or severe loss of bone density can result from the treatments that you get, both the transplant as well as the treatments before the transplant. We know that this is higher risk for patients who get a donor transplant than in those who receive their own cells, but the risks are there on either side. The risks can be further compounded if you need lots of steroids, if you're on chronic immunosuppression, if you're inactive, not getting enough physical activity. Weight-bearing exercise is indeed one of the best treatments of osteoporosis. Being underweight is a problem because your bones aren't getting enough stress from gravity. So for those of us that are heavier in the room, good job. Osteopenia and osteoporosis are both asymptomatic until you have your fracture. So this is one of those things that's good to screen for, right? So that you find a problem before it's a problem. We have good tests for screening. It's called a bone density test or a DEXA scan. It's good to have that test done in a screening way and then have it repeated every so often at the same center. There can be wide variation in results between different machines at different centers. So if you can, try to get it done the same place every time. Apples and apples, not apples and oranges. And there are things that you can do to help promote good bone health. If you've had early onset of menopause because of your treatments, getting estrogen replacement or estrogen supplementation can help promote bone health. Making sure that your vitamin D levels are adequate, and certainly up here in the Northeast, vitamin D deficiency is pretty much given. There's just not enough sun. And taking vitamin D supplementation promotes good bone health along with an adequate amount of calcium in your diet, which for most transplant survivors is at least a gram or 1.5 grams of calcium per day. A more acute and significant bone problem than having weakening of the bones is damage or death to the bones. This is what's called avascular necrosis, or AVN if you've heard the abbreviation. God bless. This is a problem that is generally not a late effect. It's more of an intermediate term. The average time of onset for AVN is about a year after the allo transplant. It's uncommon in auto transplant survivors unless they've gotten lots of steroids. You can have AVN as late as about 3 or 4 years out, although typically if it hasn't happened in the first year or two, it's not going to. This typically presents as insidious onset of pain in a joint over a period of days to a week or two, to the point of causing significant pain or impaired mobility. I'm pretty sure everyone in the room, if they had a bad ache that was getting worse over a week or two, wouldn't not call their providers. So I don't need to emphasize that too much. It can be a hard disease to treat. There can be surgical repairs of it, although the surgery sometimes is worse than the illness. Oftentimes we just recommend physical therapy and trying to work through it and restore function to the joint over time. Hypothyroidism is kind of like cataracts, right? This is one of those very common but not very dangerous problems. A lot of patients after a transplant will end up having low-acting or low-active thyroid glands, either because of radiation or because of the chemotherapy drugs themselves, or simply because it's a common disease in America even for regular people, right? It's very easily diagnosed. Most of the time it will be found by your doctors before you have any symptoms of it. Checking thyroid gland function with a simple blood test is very commonly done by transplant doctors and primary care doctors, and it's very easily fixed with a once-a-day pill. Not so easily fixed. The answer to this question, by the way, is no. Well, technically, yes. So Chemobrain is a real challenge, right? And there's going to be other sessions talking about this this week, and I'm very glad for that, because this is one of those things that a decade ago, doctors poo-pooed, right? We said, oh, yeah, you're just out of shape. Or you just got to get back to life, or do some crossword puzzles, or God knows what terrible advice we would give. And the complaint was minimized because we didn't appreciate just how serious and how common this was. We're smarter about this now. We understand it better, and our understanding is increasing over time as we do functional MRI tests and detailed neurocognitive evaluations with specialists in this area. We understand that it's common after both an auto or an allo transplant. Most patients 3 or 6 months after a transplant will have significant impairments of cognition. Typically it's having trouble concentrating, having trouble multitasking, needing to invest in Post-its. These are very, very common after a transplant. The recovery from this is a lot more variable, right? By a year out, many patients will be better, some will be most or even all the way better. By 3 years out from a transplant, most patients will be most of the way better or all the way better. But there's a set of us in the room whose brains will never work the same again. And they'll tell you, I'm not the same, and I'm not going to be the same, and they're right. And we as a profession are continuing to work hard on understanding why that is, if we can predict better who's going to be at risk for that, and even better if we can figure out how to help fix that over time. But patients who are having problems with this, I encourage you to talk to your providers. There's neurocognitive testing that can be done to better characterize this, and working with a neurocognitive specialist on trying to do brain rehab, as it were. It doesn't fix it, but it can certainly help with coping skills and can help prevent Chemobrain from ruining your lives. Fertility is a big question mark, here literally. Certainly we know that fertility for both men and women can be impacted by transplantation, and there's sessions on fertility later on this weekend as well that I encourage those interested to attend. I know those speakers, they're excellent. One thing that I remind all of my patients, and I'll remind all of you, is that chemotherapy or bone marrow transplant is not a form of contraception, right? It's just not. Even if you haven't had your periods back, assume that you're still fertile, and if you don't want to get pregnant, take other strides to make sure that doesn't happen. Nonetheless, we know that fertility can be impacted negatively by our treatments, and there are things that we can do to help promote fertility after a transplant. For men who have ongoing problems with sperm quality or sperm volume, there's a procedure called testicular sperm extraction, which is about as much fun as it sounds. There's also donor sperm is an option and widely available in this era. For women, there's in vitro fertilization options, and these can sometimes be prohibitive financially as well as psychologically, but there's a lot of resources that are available now. Groups like Fertile Hope can help make this a reality for patients who don't have the financial means or the appropriate support to get through it. So don't assume that you're not a candidate simply because you're not daddy or mommy Warbucks. Surrogacy is, of course, a very valid option. And I always speak to my patients who have fertility concerns about adoption. I'm not going to proselytize in this room, but I think it's an amazing thing to adopt. And I can tell you that my patients who have pursued adoption, I can't think of a single one that's regretted that decision. Infections after a transplant are, of course, a problem, and there's risks that vary where you are in the course of your transplant recovery. During the transplant, certain infections, immediately after a transplant, others, and then in the long term, others yet. What can we do to reduce the risk of infections besides the fastidious hand washing and avoiding sick contacts and everything that your doctors drill into your heads like the sergeants they are? We can vaccinate, right? And increasingly, transplant centers are being very smart about the post-transplant vaccination process, and hopefully everybody in the room knows that there's this list of vaccines that you should be getting over time. I will highlight influenza vaccination, and influenza vaccination is important on an annual basis for transplant survivors, both to prevent the flu, which can lead to flares of GVH or can lead to irreversible heart damage, not just having to sit on the couch and drink chicken soup. Chicken pox or the shingles vaccine is an often asked question, and right now there's no single standard. Different transplant centers do different things. There's a black box warning on the vaccine that people with impaired immune systems shouldn't get that vaccine because it's a live virus. There are 2 late-stage shingles vaccines developed right now. Hopefully one will be approved in the next couple of years. Those are both inactivated viruses that everyone in the room should hopefully be eligible for when they're approved. So that's a big laundry list of problems, right? So thinking more generally about survivorship, the goal of survivorship really is to maximize your health, your quality of life, and in so doing, and at the same time trying to minimize those problems that can happen through transplant. This is really the goal of transplant survivorship. So the number one question that I get asked, Dr. Manasar, is there something I can take? Is there a pill or an herb or a vitamin? What can I do to stay healthy? And the single best thing that patients can take, right? If only that came in a pill form, it would be FDA approved tomorrow, and I could charge you $10,000 a month for it. Unfortunately, I have yet to come up with a pill form of exercise. I would start taking it myself. But it does have a lot of benefits, particularly for transplant survivors. We know that it decreases the risk of heart disease or stroke. It can reduce or reverse the risk of diabetes. It can help your blood pressure, get you off those BP meds that make you tired. It can improve your cholesterol. It can reduce the risk of certain types of cancer. Breast cancer, colon cancer, uterine cancer are all reduced risk for patients that get exercise regularly. It's the single best treatment for weakening of the bones, and it definitely is one of the treatments of Chemobrain. The best studied exercise for Chemobrain by and by is yoga, but it doesn't need to be the hot yoga. Any yoga does. So how can you be more active? Really, what I encourage my patients as the first step, particularly if they're not sort of exercisers at heart, is to get a pedometer. It's a very simple thing. It's a pretty cheap thing. And for many people, it can be really life-altering in how you approach what it means to be active. The goal is to take 10,000 steps a day, on average and every day. And whether you buy a fancy pedometer, or whether you get an app on your iPhone, or whether you get a little wristband, or whether you buy a $5 one from Target, whatever you're doing to keep track of your activity, you'll be surprised, if you're not already doing this, at how much or how little you might be walking. And it'll force you to think about how you sort of conduct your body on a daily basis. And simply taking this one step, so to speak, can really make a drastic impact on your overall wellness. What can you do with your providers? What I try to encourage is what's called a life plan, which is a wellness plan that you can develop with your providers, your caregivers, your transplant doctors, other doctors, your primary care doctor, that incorporates all these different risks. Your lifestyle, your transplant stuff, your family history, your other health problems. Can lay out what your screening should be for late effects of cancer, lay out what types of prevention should be done for you. And this is something that can be adjusted over time. As you get healthier, as you get sicker, adjustments can be made so that it's a dynamic document that encapsulates your care in an ongoing way. So what goes into this life plan? Issues about your cancer therapy, your family history, your lifestyles, your other health conditions, and it all gets put together into this single document called a life plan that then is something that you can share with both your transplant doctor and your primary care doctor to help guide your care as a transplant survivor. If you guys don't already have a survivorship care plan or a life plan developed, I encourage you to talk to your doctors about it. It can be a very helpful thing and can serve as a little bit of a rock for you as you go about your life as a survivor, as a patient, to help guide your care. So work with your team, learn your family history, know your treatments, and keep this available to you and your providers. There's a lot of resources for you guys as survivors. I encourage people who want to learn about some of the medical facts of this. Survivorshipguidelines.org is a pediatrics-based guideline. It's through the Children's Oncology Group. But a lot of transplant survivorship centers, including ours at Memorial, use this as a template or as a building block for developing our survivorship guidelines. And it has a ton of very detailed and very rich information. Marrow.org and CIBMTR.org are both excellent resources for additional medical level knowledge. And then Livestrong and PlanetCancer.org are both excellent resources for more lay levels of literature and information. But work with your doctors, learn from them, and let them learn from you. And lastly, I'll give a call for action to all here. Coming today is an amazing step, and is brave of all of you to come and acknowledge the need and the value in learning more about your health, networking with each other, but take a step forward and give back. Find a way to engage yourselves in the transplant community at large. Volunteer, donate, find trials to participate in to help advance our knowledge of care for others so that we can continue to improve in our care of you as survivors and the survivors that are yet to come. Thank you very much.
Wow. I'd like to thank Dr. Matasar again for that great presentation. You didn't leave anything out, I don't think.
You can't do this all in
Right. Nope.
But it's a start of conversation.
So, with that, I'd like to now invite people up to ask the Dr. Matasar or Ms. Krimmel some questions, and not about coffee. If you want to come to the microphone, absolutely. Yes.
I would like to ask the doctor if he could expound a little bit more on the ferritin. My wife has been out with a bone marrow transplant at Memorial Sloan Kettering, and we noticed that, am I speaking loud enough? Okay. That her levels have gone up a little bit, and we go back every year to our survivor nurse practitioner nurse, and she's here today, Cara Maceso, I guess that's her name. So if you could talk a little bit more about that. So we want to know in terms of, as a caretaker, where do we go? I mean, what do we do? I mean, it's going up.
I understand. So it's a great question, and it highlights a few issues that are more broad than even just your and your wife's care.
Do you want to repeat what he's asking?
The question was specifically for his wife, who's a transplant survivor. She's had slowly climbing ferritin levels over the last few annual checkups in survivorship, and what should be done about that? This highlights a few important issues. The first is how stressful it is to have all this lab data, right? It can be terrifying. All of these numbers with stars and exclamation points and arrows and highlighted in red on computer screens can be just terrifying. And sometimes there's too much data. And it's easier for doctors to filter this sometimes because we understand the patterns, and a lot of medical care is about pattern recognition. But for people who are living this for the first time, it can be just absolutely mystifying and terrifying. For the specifics of your wife, obviously I don't know her care intimately. I'll say that elevated ferritins without evidence of other problems like inflammation of the liver, damage to the heart, other organ problems is not a problem in and of itself and is generally just monitored. Ferritin is a very nonspecific blood test. It's what's called an acute phase reactant, which means lots of things make it go up, like inflammation or illness or whatnot, and does not in and of itself need to be treated. But it's a useful test for patients who have evidence of iron damage because it can be a little bit of a canary in the coal mine, and as the iron is leached out of their body, medically that number comes down, and we use it to gauge how much treatment is needed for iron overload and when we can stop those treatments. But in and of itself, it doesn't sound like your wife needs to worry about her ferritin level if there's not other problems.
Added to that, if she's not transfusion dependent anymore as well, that if she's not getting transfusions, that would also
Point taken.
Lead against being more concerned about it.
Good point.
I'm sorry, I wasn't quite finished. Part B, her ALT and AST blood tests have elevated a little bit above the norms. Does that have anything to do?
Mild elevations are generally more problematic to the computer screen than to the patient or the doctor.
The two aren't related? The ferritin and the ALT, AST?
Without knowing your wife's care, it sounds like it's not likely to be a major issue.
Okay.
But certainly talk with the team. Raise your concerns and let them address them.
Okay.
Much of this, we can be sometimes afraid to ask these questions in the clinic, right? You don't want to be a nudge. You don't want to bother your team that takes such good care of you and that love you and that you love. But ask your questions. We love to answer them, and we'd much rather alleviate your anxiety face to face than leave these questions festering in your minds and causing stress to you.
Thank you very much.
And remember, They're working for you.
Yeah, we're
So
all
you
together.
always ask them the questions you need to ask. Have another question?
I have a question about wasting syndrome and the inability to gain weight after transplant. It's sort of it's another metabolic issue, but the opposite of what you were talking about, and what you know about it, or if it's real, or what is it?
It's definitely real, and I guarantee you that you're not the only person here today with that question, because I talked to someone else in the line getting coffee this morning that wanted to ask me the same question. So it's a real issue. We don't know a lot about BMT wasting, but we know that certain survivors have a terribly hard time putting on weight. They can eat, they have a great appetite, they stuff their mouths, but they don't gain weight. I'll tell you that it's more problematic to patients than it is to doctors, because we don't see a lot of medical late effects associated with an inability to gain weight or put on fat. It's a cosmetic problem, and it can be quite distressing to patients. But as a late effect, it ranks relatively low in riskiness in terms of jeopardizing your overall health. Why it happens is a great question, and hopefully someone will figure out the metabolic pathways involved in a scientific way. If they haven't shared that information with me yet.
Thank you.
You're welcome.
My question has to do with if you were receiving bisphosphonate therapy routinely for and then it was suspended because you went through an allotransplant for AML, how soon do you start up the therapy again, and is there a high risk factor because it was suspended?
She said she I'm sorry, you had multiple myeloma, is that what you said?
My husband has a triple header, AML, and MDS.
Okay.
And he was routinely receiving Zometa. It was suspended because he developed AML and went through an allotransplant. We kind of feel like the MM's been pushed off to the side because we have a different healthcare team for the
Now,
AML.
did he receive several years of bisphosphonates for the myeloma, or just a short period of time?
He's been on the Zometa from 2003 to 2013.
Yeah, that's a long time, I would say. And you can review the ASCO guidelines on that, but they usually recommend several years, up to 2 years, and then if the myeloma is not active, they could say that you could stop it. That's what I would say without knowing your husband's full care. There are risks of long-term bisphosphonate therapy, including a vascular necrosis of the jaw and problems with dental. We've seen that pretty frequently. But if the myeloma is not an issue right now and there's no bone disease to be concerned about, I would consider focusing on the other things of the care and not so much with the bisphosphonates at this point. Would you agree?
Absolutely.
Relieve my anxiety.
Thank you.
But again, this goes back to the question of communication, right?
Yeah.
So it's important for your doctors to communicate with you why they're doing or not doing things.
Right.
And it's important for you and good for you to ask those questions and challenge them and say, hey, he has myeloma too, don't forget, even though he's in remission. Should he be getting bisphosphonates? What are the risks? What are the benefits? What are you thinking? So that they can share their thoughts with you so that you can understand that they're not putting the myeloma on the back burner, but that they are indeed trying to take all of his health into consideration.
Or going back to your myeloma specialist every once in a while to just connect with them to see if there's anything, that you're missing right now would also be a good recommendation.
Sure.
Thank you.
Hi, I had a question about your screen about loss of childhood immunities.
Yes.
And there was no distinction that I saw on the screen between autologous and donor transplants.
Deliberately.
There isn't.
I'm sorry?
Deliberately, no distinction.
Okay. I understood I'm an autologous transplant survivor. And
Congratulations.
I understood that you didn't have to get your baby shots again. Is that not correct?
I would say that most transplant experts would disagree with that statement in 2014.
Yeah.
Okay. Good.
Yeah, we usually follow the same recommendations in our institution as the allogeneic transplant
Okay.
recipients.
Good. Thank you. That's helpful.
So I had MDS, autologous, not autologous, sister, full match. So it's about a year and a half out.
Congrats.
So what's the story with hair?
You're asking the wrong guy.
Sorry. I know. It's just like, I'm Italian, have fabulous
So is
And now I have-
this your natural hair, or is it a
No,
prosthesis?
No. I mean, it's thin, brittle, patches. There's no hair. I don't even know what I got. It's just unbelievable and and frightening, and just I don't. So what? How long does it take? Is this it? Is this what I? I'm alive. Hallelujah. But I'd like to have some hair.
Sure. Well, a couple things come into factor with alopecia, which is hair loss for people. First is endocrine dysfunction. So if you haven't had your thyroid checked, you should, because that can cause hair loss. If there's certain medications, some medications can cause it. And lastly, something that you see pretty frequently is if you have active graft versus host disease, there was definitely be impairment or thinning of the hair for a long period of time. I can't give you an exact number, but I do think it's not completely unusual for someone 18 months out to still have pretty thin hair.
Okay. Yeah, I had skin graft versus host, and I took steroid treatment from June through October of last year.
Yeah.
That can totally stunt the return of what was undoubtedly lovely hair before. So give it time.
Yes.
One more question.
Within a year or a year post allo transplant, if the chimerism is showing, if it's a mixed chimerism and you don't have 100% of your donor, the bone marrow is showing some residual disease or more than residual disease, but your blood counts are normal. It's a wait and watch. Do you contemplate DLI? Do you treating sweet syndrome associated with it, low dose cortisone, and for how long? And is 7.5 to 5 considered low dose and is safe for a long period of time?
So this is obviously a very specific and quite sophisticated medical question. Probably not the best venue for this, although I'd be happy to speak to you afterwards. The bottom line is that many times after a transplant, this issue of mixed chimerism and incomplete engraftment and sort of this coexistence of the old and the new can be a challenge for patients. And it can be a challenge for doctors to know how best to manage that. DLI has good and bad about it. DLI stands for donor lymphocyte or leukocyte infusion. It's a boost of the donor immune system to the transplant recipient. It carries risks and rewards like the transplant itself did. So these are highly individualized decisions. Thank you for the question.
So I think the takeaway from today is talk to your healthcare team. Communication, communication, communication. Make sure you're talking with your physician, your nurse, the nurse practitioner, the PA, whoever you have that relationship with, to make sure you're talking about whatever is going on with you and whatever else you need to know. And again, I'd like to thank Dr. Mattisar and Ms. Krimmel for not only presenting but answering questions, and I'm sure they will hang out for a little bit if there are any other questions. So again, thank you.